Well, good morning. Let's do a mic check. Y'all let me know if you can hear me and things are good. Good morning. Tell me where you're coming in from. Good morning. Good morning. Good morning. Oops. All right. Let's see where everybody's coming in from. Good morning. Today is Friday. I don't even know the date. August 23rd. That's what date we're at. How's everybody this morning? Good morning. All right. We got Miss Frida from Dallas. Hello. Welcome. Welcome. I'm glad you're here. All right. So it sounds like I'm working and the mic's working over here. It seems like I always have tech issues and I don't know why. And I know the setup is right, but I don't know. Technology. You got to love it sometimes. Okay. So for the sake of time, I have a lot. I am going to get started. And if you guys have questions as we go along, just drop them in the chat because at the end, I'm going to try to answer as many questions as I can. And if I can't get to them, then I will try to do a recording with the rest of the answers because I know this is definitely a heavy topic. And I'm looking for trying to just provide a really good basis, a basic understanding of where we are and what it is because I realize this is a topic that we don't talk about in grad school and it comes up briefly, but you really have to have the experience in order to really understand this. So this is kind of where this comes from today. So let me get my share screen happening going on here. All right. Okay. So I hope everybody can kind of see that. Let me get things moving here. All right. So we are going to be talking about suicide prevention and doing some risk assessment this morning. Um, I just want you to know that this topic is heavy. It's one of those things where if you need to step away, do that. If you need to kind of just take care of yourself, if it's just to let me know or you walk away or do what you need to do to kind of take care of yourself on this one. Okay. So today's objectives, we are going to be focusing on just again the basic understanding how mental health and suicide are connected, identifying triggers, warning signs, risk factors, any comorbidity that come up, and just how does this look every day. That's all the work that I do personally is around what is happening every day, not what's in the future, not what's in the past, but like what does that look like today. um and then hopefully you will walk away with something new, something, a different perspective, just something. Okay. So if we haven't met, I'm Shauna. I'm a wellness educator. I'm a Texas supervisor, as well as I've been a therapist since 2012. I do have my private practice where I work with not only other therapists, but as well as helping professionals. And I offer like supervision and a couple other things. And so the experience that I have around assessments and working in the jail, working in like settings where you have to be solution focused is where a lot of my information comes from when it comes to suicide prevention, because you have to be quick on getting the information you need in order to understand where your client is and be able to make a determination if they need to go to the hospital, seek like MCOT, or can you just safety plan with them? And I have my own issues about safety planning, but that's kind of where that is. All right. So as we move forward, again, we are going to start with just some basic understandings and definitions, just because this is the basis of everything that we do. And if we don't understand these pieces, then there's going to be an issue with how we are able to do this. Okay, so let's start with anxiety. So we all know that anxiety is it could be a real or perceived fear. Um, just think that it is something that tells our body, do we need to go in flight, fight, or freeze? It's our response. And it's not that it's the anxiety or the situation coming at us, it's just our response to whatever the situation that is happening. So keep in mind that this is the way our body responds. If we are good at listening our body is going to tell us exactly what we need to do. All right, so we know the anxiety is kind of dropped into the 3 categories in that new DSM, and can you guys believe that we're gonna have another new DSM? Like, I can't believe that, but side note, um, anxiety, kind of OCD type things, and then trauma, stress related things. So, when we think about, suicide, where sometimes it could be in any of these categories where it may kind of show up. Okay, so just a quick review again, generalized anxiety disorder is just the overall feeling of anxiety that we get, and it has to last at least 6 months in order for us to get an official diagnosis. Now, we can have traits, we can have some things that are going on with us, right? And it brings anxiety. That's life. And I'll show a chart here in a minute that explains kind of like the thought process that I have around what that actually looks like in everyday life. Okay, so keep moving forward. Here are just a few complications that can come up. Just think about that some of the symptoms. I was actually reading a study the other day where it was specifically talking about substance use, though, but it was talking about how um, there's these symptoms you have in substance use, you have symptoms in anxiety, depression, all these different symptoms. And they, it was crazy about the amount that overlapped. So, how can you really tell, like, if it's really anxiety, if it's really depression, or if it's something else? But I just found that interesting that there were some symptoms, like I have to pull up the list, but there were some symptoms where they were overlapping in like 8 different diagnoses. It was crazy. It was definitely crazy. Crazy, crazy, crazy. Okay, so here we are with depression. Depression, we know it is typically a common medical thing, even though that's not how we as mental health professionals are treated, but it is technically a medical condition. It's not really sadness, but yes, you feel down, it affects your thinking, your physical activity. It's all the things that are beyond like, "Hey, this happened and I'm feeling sad." It's a little bit past that. Okay, just a laundry list of here are symptoms of depression if you didn't know. Again, lasting 2 weeks or more, and you gotta kinda hit these different 9 categories. I have a lot of this stuff is a little bit more detailed in here because I do this presentation with other groups, so that's why it's a little bit more detailed than maybe most therapists would know or understand. So all right, here's a few type of depression. So I specifically work with not just general depression, but a lot of the clients that I work with, it either shows up in PMDD or it shows up in pervasive depressive disorder. That's what they used to call dysthymia. Basically, you show up at work, you look fine, but you're not really fine. So and again, here's the one that I work with the most. It's really just thinking about this person looks normal, but they're not really quote unquote normal. Okay. Here's some things that kind of come up when it comes to kind of anxiety and depression. It's like we have to look at stigma. We know that that's really big in mental health. We have to recognize that it's not technically an illness like, diabetes or heart disease or anything like that. But we also have to consider that it is a factor on why people have a hard time. And as we move through this presentation, this is something that we have to keep in mind that we are meeting people at their lowest point in their life. And we have to be ready with the skills in order to help them to that place. If you were looking at mental health or treatment therapy on a spectrum, you have therapy on one end and you may have coaching on the other. And we're trying to get them back to that baseline when we're doing therapy. Okay, here's a couple of other risk factors. We do know it's a little bit of everything when it comes to mental health. It's genetics, it's our brain chemistry, it's things around gender, as we know, it's situational, it's major events or environmental factors. There's so many reasons why people kind of go start experiencing more mental health issues and depression in particular. Okay, and so here we have coexisting. So there's the overlap between mental health or depression, I'm sorry, and anxiety. And there is a little bit of overlap, and just kind of keep that as we go. Okay. So this is how I like to explain it to the clients that I work with. Is on one end you are manic, you're elevated, you probably are doing crazy shopping and spending and like just you are out there. On the other end may be a zero and feelings, thoughts and not wanting to live. However, I like for my people, and you should too, to live in the 4, 5, 6 range because this is where we are participating in everyday life. Things are, happy, copacetic. We're like in a good mood. We're not necessarily on autopilot, but things are good. And this is where we generally want to live every day. Now, a way to explain that is we have moments in our life where we are either up or down. And so, like, say, like someone is getting married, we tend to naturally have some anxiety around that because we're like, wait a minute, I don't understand what's happening or what's going on, or there's the butterflies. That would be more natural. It's an anxiety. We go up and then we come down. Then on the other side, maybe someone passed away and we do naturally feel sad. But sometimes when that goes beyond the sadness, that's where we would be on the lower end of the scale. So when you're giving the scale or you're trying to get people to identify where they are, always use real life experiences so that they can kind of relate to whatever the questions are. Okay, so here's another piece that we have to throw into the mix is substance use. Now, when you're doing an assessment, you're not only asking about anxiety, depression, and all the things that are going on in their life. We need to also ask about substance use because it's could be a contributing factor of why someone is in the negative space that they're in or in suicide. Typically folks who are heavy users often go towards suicide because they're already, so like let's take alcohol for instance. They're already depressed, right? They're already feeling kind of low. Then you add alcohol to the mix. And now all of a sudden, because alcohol is a depressant, you've just made yourself even more depressed, which sometimes lead into the suicidal thoughts and the suicidal ideation because they're thinking about something negatively, thinking about the past, can't change it. And then all of a sudden they're thinking, oh my goodness, what am I going to do? And then the thoughts come up. So always ask about if there's some level of substance that they need to be aware of because it does play a role. Now, there's some interesting things about like, okay, if you have a problem, what does it clinically look like? Because someone could clinically not be clinical, right? But they could be like users or they like to engage. And so there's a difference between being a heavy user and is clinically diagnosed versus someone who is maybe abusing the substance. So that's always a good thing to kind of look at. When we're looking at the spectrum, this is exactly what I'm talking about. We have our casual, non-problematic folks. That probably would be me because I am a super, super lightweight. Then you have someone who would be chronic dependence on the other end. And so you have to think about where do people fall on that spectrum and how is that contributing to um the way that they're thinking and the way that they have their daily functioning. Okay, so let's get into the kind of heavy stuff and let's keep moving along. Is everybody doing all right out there? Um, can't see the slides. Ooh, I'm just like going through this and you guys can't see the slides. I have my stuff covered up. All right, let me try to reshare again. See, this is what I'm talking about with sharing, but I'm glad you guys can hear me. Do you guys have any questions as we're moving along? As we're moving along, let me know if you guys have any questions. Let's try this again. I tell you, tech issues. All right. Can you guys see that? Okay. So let's keep kind of trucking along in here. Um, so let's defining what suicide is. All right. Sorry about that. I'm over here and I got my chat covered up. I should really have the chat so I could see it. Okay, so we know that suicide is where someone is self-inflicting dangerous, like injurious behaviors to themselves. And we're going to talk about the difference between that and self-injurious behaviors in a minute. But this is basically when a person feels like they have no other way of solving whatever their problems are. And so this is the act that they engage in. A suicidal attempt is where they've actually engaged in trying to harm themselves. Now, the difference would be is in ideation, we're just thinking about it. Sometimes we're planning it, not always, but it's just a thought that they have. Those thoughts can be fleeting, they can be constant, they can be somewhere all over the place. They could be situational. So self-interest behavior, this is the one where they're intentionally harming themselves by cutting, scratching, headbanging, pulling, all those things. The difference between this and actual suicide is that self-interest behavior is typically a way to release pain, to release something, to release the way that they're feeling. And usually when you're doing your assessment, you want to ask, like if it's unclear or they're unclear and can't give you clear answers, you start asking about self-interest behaviors to determine, is it just they're releasing or is it that they have intent to end their life? Difference. So suicide prevention is basically what we're doing now. We're educating ourselves, we're having compassion, we're stepping in, we're doing planning, prevention planning. It's all those things. Risk assessment is the place where when we're doing our assessment, like our suicide assessment, and we're checking into SI, then what are the things that are contributing to those thought processes? And we'll go into that here in a second. Okay, so let me know if you guys cannot see the screen. Just keep telling me in the chat if you can't see it. Okay, so here I just started pulling stats, and this is where we are. And these are as of, I think this one's 2021, the end of 2021. And it just, here are just some stats when it looks like worldwide. And I'll get more specific as we go through this. Okay, so in the US in particular, we are 11th when it comes to suicide. It is 132 suicides per day, which is about one every 11 minutes. That's a lot of people. Um, on average, it's estimated 1.7 million are having attempts. Um, and then you have 12.3 who've had serious thoughts, and then you had 3.5 million who actually had a plan. And so that's not saying that everyone falls in these categories, but when you're at some point in time, like if you ask certain people, they're like, oh, yeah, I've thought about suicide. I've thought about this before. Now, personally, say I've never thought about suicide personally, but I do recall after having my daughter, and she's what, almost 12 now, there was a period where, it was, I guess, in that postpartum period where I was definitely feeling down and having the baby blues and feeling, but I never felt like suicidal or was thinking about it. But there was that piece where I was just like, what the heck? And I couldn't like really name it or put, my thumb on the pulse of like what was going on. And when I get a little bit later in this, I'm going to show you how I kind of explain all of those too. Okay. So, the thing here to also look at is that firearms typically is pretty lethal. Men are more common to have completions versus women. Men's completions are usually more violent versus women's aren't. Okay, here's another stat that just looks like. Now, if you look at suicide is not actually on this list, But when you're thinking of what are the top reasons that people are passing away as of 2021, this is your top list. This is it. This is where it falls. And again, suicide is number 11 on the list. This is another just kind of view. And I like this view because it shows in the age bracket. And you see that 10 to 14 and 25 to 34. Actually, you're 15. And so basically from 10 to 34, it's pretty high on the list. Um, and I think a lot of it these days has to do with where we are in society. Um, and then there's the lack of like mental health support. There's a lot of reasons for that. Okay. And so here's just another look where is it a little bit more common than it is in other states. Now, the darker blues is where it's pretty heavy. Now, I will say places like maybe Alaska, Montana, you have to consider the weather. Um Maybe there's other reasons why some of the lower states like New Mexico, like New Mexico is very heavy with um Native Americans, and Native Americans are known for drinking quite a bit. So there's some things that we have to look at. Okay, so here's another kind of view. In the United States as of 2019, again, firearms was like pretty much the top thing for men. And then the big thing for women, it was kind of mixed. Like it's interesting to see that they usually have less lethal ways, but it's pretty mixed. Taking pills, things like that. Here's just another view. Okay. So when it comes to ethnicity, you have your American Indian, which is the top one for males. They have the highest rates of suicide. Again, it's probably, and this is just my thoughts, that it could be connected to their drinking because they drink a lot, a lot. So, and then after that, we have white or Caucasian males, which is pretty heavy. Now, I wouldn't know, like, I guess it depends on what's going on with that male, but it's just interesting that it's pretty high as well. Here's just another look. I know I had a lot of stats. Here's another look at that. How American Indians or Alaska Native folks, they're pretty heavy on the list. And just another one when you're looking specifically at men, and then here at women. Now, this is interesting for women because again, American Indians or Alaska Native, they're high on the list yet again. So here's another one by age. It's just interesting to see how it's more common among males. I think females talk about it a lot more, but it's more common among males. And just another one, and all of these stats and things you can find between the CDC and some of your suicide prevention folks that kind of follow these things. So here was an interesting stat that I found. At the end of 2021, for every completed suicide, now remember we're using completed versus other terms that have been out there before, that person has experienced at least 3 hospitalizations, 8 ER visits, 38 times that they have self-reported within the year prior. And then there's that 265 people that are seriously in that space. But just think, for every one suicide, there's 3 hospitalizations for that person before they did it and 8 ER visits. What does that tell you? One, it could be that people have a hard time self-regulating and going with the punches and going when it's hard. Two, it could be just maybe they don't have the support. Maybe it's community support, it's family support. I mean, I don't know, but that's just an interesting thing to see. It's going up over time. There was a period of time where it wasn't a lot, and now it's going up. Um COVID is probably didn't help that at some point, but it's getting higher than homicides. And there are some cities that are pretty high in homicides. Okay, here's another interesting stat. So, can you believe that the one job that has the highest suicide rate is farming, fishing, and forestry? Like, and then followed by construction. You would think that it's like something else, and because you hear a lot about other areas in the news, but these two are at the top of the list because it's very much connected. Well, the first one's very much connected to their livelihood. And if their livelihood is not well, what do you think could happen? Construction, I found out that because they have the access to the means a lot of times, that's why theirs is pretty high. Here are just some other ways of kind of looking at that higher rates. Now, I work with helping professionals and first responders. They are pretty high on the list, but not as high as those two. And just another one, kind of how that looks. I probably should take some of these slides out. Another way of kind of looking at that. Okay, so here in Texas, this is where we are sitting at. It's the 11th leading cause in Texas as well, so the United States as well as Texas. And here's that interesting stat right here where it says almost 3 times as many people died by suicide in 2019 than alcohol-related motor vehicle accidents. So DWIs, driving while under the influence. More people have died from suicide than driving. Interesting. Okay. So as we kind of go along in here, there was a study done in 2010 by the Air Force. And basically, the study just states that if we talk about suicide prevention and suicide, that we actually reduce the rate of people actually engaging in the behavior versus increasing it. And so a lot of people think like, well, if we talk about it, then we're putting the idea in their head, and that's not true. Here at the Cambridge study that was completed, it was a study over time, like a review study. Um, and so I left this one in here because it's specific to, I know, first responders, but there were 56 had some inclusion identifiers that strategically support first responders and first responder mental health and well-being. So basically there's things that identify like, are they going to engage or not? And then it was the piece about normalizing behavior, normalizing conversation around mental health. And I left this one in here. And I know that we're not technically talking about first responders, but it's the same concept that we have the identifiers and we also need to normalize conversation around it. Okay. So let's go in a little bit more detail. So I like to sort of use the SAVE model, but as you see, I have a list of all the other ones like AS, QPR, ACE, there's a whole bunch of them. But I think the easiest one to use is SAVE just because it's easy for us as clinicians to just kind of engage in that in natural conversation, but two, this is something that if you need to teach someone else, there's a way, this is something that you can teach them pretty easily. Okay, so when it comes to the signs, we're looking at what are some of the daily stressors? Was there a specific event that happened? Like, was there a death? Was there some relationship problems? Are there issues at work? Like, what is bringing some of the issues to the table for clients? Is it that they have CPS involved and there's problems with their children and their partner or co-parenting? There's changes in their routine. Now, we also have to remember that in our stressors, it's not something that necessarily happened like say today or yesterday. It could have been something that happened 6 months ago or a year ago, and it's been the stress or whatever is happening has been accumulating over time. Some other things that can kind of catapult into thinking this way really is the end. So think grief in a sense. So ending a relationship or a marriage is grief, right? A death of a loved one, a death of someone. There's legal problems. Now all of a sudden they're spun into things legally. Um there's major financial problems. And then there's something that happened with work. Now, if you were to come to me, I would say, what are the things that most people deal with in life? A birth or death, a wedding or divorce, um, a job change or financial change, a housing change, or a health change. These are the five areas that most people, living and breathing humans, deal with, but yet it's on our list. And so we have to consider that when someone is experiencing these daily or things that can happen to anyone, are they happening too frequently? I had someone I was working with the other day where he experienced like all five of them in like the last 2 years. And then no wonder he's having these thoughts now. It's because he was overwhelmed. So, what are some more, what could increase the risk? So, not just dealing with all of these factors, right? Again, there's the alcohol and drug issue. There's feeling like I'm going to be a burden to other people. There's, they're actually talking about hurting themselves. They may not have a plan, but again, we'll talk about that in detail. There's the I'm going to show them revenge piece. They're not sleeping well, they're not eating well. So think of when someone comes to you as a client and they're having trouble and you're trying to diagnose them. These are the same things that you need to be looking at when it comes to suicide, but it's just on a higher, more pronounced level. So, what would be considered more of an immediate risk? So, now maybe something changed, like things were fine yesterday and then today they're not, like that kind of immediate change. And you notice that there is a huge change in their demeanor. Um, maybe they have been talking about suicide, but maybe the conversation around it has been different because there are some people who their baseline is kind of negative or suicidal kind of connotations. And then sometimes when that changes, that's when you want to definitely start looking at risk. Um, a more immediate risk is like maybe they're talking about it, but now they're planning. Um, they're feeling more hopeless. Like everything has increased from what is I won't say normal, but what things have been happening before, and it's changed, it's different, it's increased. And we really want to start asking the questions. So here are just some verbal cues that may come out. This is not an exhaustive list, but you want to think about like start reading between the lines. Like if someone says something and you're not sure, but it sounds like it could be, start asking questions to see where they are. So asking a question, and that's the next step of that. In the save. So we're gonna just start asking questions. Now, there's this conversation around should we say, are you killing yourself? Are you thinking about killing yourself? Are you thinking about suicide or have you had any thoughts about taking your life? So being very specific versus are you thinking about hurting yourself? Because that could be very different. And so we have to be careful on when we're talking to people, how direct can we be versus maybe how a little bit passive can you kind of ask those questions. Now, the role that I have, because I work with EAP and I know we have to take a softer approach, and this is my everyday job, I typically ask, have you been thinking about hurting yourself? I do typically ask that just because our approach is a little bit different. But when I start getting the answers to that, that's when I start asking more questions to get the idea of where they really are. Here are just some things that you always want to keep in mind about yourself when you're working with someone. Just staying calm, just managing your tone. How are you speaking? Like not arguing. All about having good rapport with a client or a potential client if you're working with them. We always want to validate a person's experience. This is the V in here. Validate the experience. So the reason why we want to validate is just because it may be that they're in this place and they feel like no one is hearing them. And maybe it's that they don't understand what they need to do or what they can do, or maybe they're stuck or feeling overwhelmed. And so sometimes just a simple way of validating someone and their experience may help them understand or see the way out or see the difference. So we always want to validate their experience. If you don't know, motivational interviewing is a great way to validate experience. So then we want to encourage treatment and expedite getting help. Now, I know we are technically the helper, so it depends on your role that you're in. If you're in a situation where you're working with a client, say in your practice, do they need to go to the hospital for further treatment? Um, do we need to change the safety plan? Do we need to make sure there are measures at home so that they don't engage, right? We want to make sure that all these things are happening because we don't want to leave any room for them to just say, well, nobody told me. We don't want to do that. Here are just a few things of here are some increased risk. So again, anxiety, depression, PTSD, and substance are the big ones. There's the social economic status when it's typically lower. Um, they have a prior history of suicidal attempts, especially within the last, I think it's like 3 months. You want to look at that. Is there a family history of any of it, especially completions? Are they socially isolated? Um, and then are they exposed? Now, something that comes up is like when you're working with, like, say, teens or young adults, if you have someone that is completed, then sometimes that can create like this feeling that when someone else is feeling that way, I have the answer on the way out because they have been given an example from before. So just something to kind of be mindful about. Okay, so here are some other things we need to consider as we're going through this. The intent, meaning, do I really want to end my life? That's the intent. The answer is typically yes if they have the intent. If they say anything kind of like outside of that, then there are some other things that we can kind of look at, like protective factors, and we'll go there in a minute. Do they have a plan? Am I going to crash my car? Am I going to take pills? Am I going to use a gun to shoot myself? I've heard some elaborate plans that made sense. They had it down to a T, but then they didn't have the intent. So think about what are they saying that they're going to do? Crashing their car into ongoing traffic. Like, I've heard some crazy things. Then there's the means, meaning they say they're going to shoot themselves, right? But do they have a gun? Do they have access to a gun? And if the answer is no, then that means that plan is not good. Again, access, that would be means and access. Same thing. If they're planning a gun, if they don't have access to the gun, then that's not really a good plan. So always check for when someone is talking about suicide, check for intent, plan, means, and access. I'll go here in a second. This is all going to come together in a second. Just it's going to come together in a second. It's going to make sense. Okay. So here is another way of checking in with the means piece using calm. So basically it's just understanding do they have a plan? What is it? Do they have It's just doing kind of the assessment around the means and understanding that. This is also good for kind of like first responders. I'm just going to throw that out there, but it is in helping professionals. This is a good one for that one. Okay. So, oh, we went over that one. I should take that one out too. Okay. And then so what are some typical obstacles that people have to just intervention? So what I hear a lot is if I go to the hospital, I might lose my job, I might lose my house. There's the money issue that comes with all of that. There's what are other people going to think about me? Um, how, you know, how am I going to be not a burden to others? There's so many factors that come into why a person may not seek help and then stays in this place on why they are engaging in this behavior and in this thought process. So this is where as you're digging through and understanding like what is going on, you have to check in with all the extra pieces even outside of like what would it look like if you got help? And maybe sometimes it's just planning or troubleshooting on how to mitigate some of these obstacles. So what I was talking about before was protective factors. So this is where when someone starts talking about suicide, and then they would say like, well, because of maybe one of these things on the list, I can't do it. I had a client the other day, like I was saying, he was talking about all these reasons. Now, mind you, they were valid reasons that he had all these things wrong in his life. And then after all of that, the one thing he said is I can't do that to my family. I would be afraid of what they would how they would feel if I were to do that. And because that was the one thing that was keeping him here on this earth, I encouraged him, have you been honest with your family about where you really are? Not just, "Oh, I'm having trouble," like that conversation you have and you say, "Oh, I'm just having trouble. This is what's going on, that's going on." But an actual conversation of, "This is what I'm thinking. This is why I'm thinking it. This is what's going on with me, and this is where I am." And he said, "No." I said, "Well, that would be the first people I would reach out to and maybe try to talk to them because I'm gonna imagine that if you came to them differently, you're gonna have a very different response than you normally would." Because in the past, he mentioned they were telling him, "Oh, you're an adult. Basically, you need to just grow up and suck it up and adult like an adult." And I'm like, I think you'll have a very different response. So that's how kind of things play out. So, how can we support our client? We have to remember that our clients are not always in a crisis, even though they may say they are in a crisis. This is what's going on. They are not always in a crisis, and we have to be mindful of that. So, some things that you can kind of throw out there. I have a little list kind of behind the scenes. So, you can do some radical acceptance. You can do some cultural humility if you need to do that. Maybe just some intersectional approach between like race, gender, sexuality, like just kind of looking at that. Maybe a little storytelling, building a community, expressive arts therapy. So, some kind of art therapy like drama, music, things like that. Something nature based therapy. Now, that's something that I would do because if I was working with a client in the community, that's something that I typically do just because I like being outside and going for walks. So, and it's very nature based is very helpful. Body centered approaches, yoga, tai chi, dancing, something where we may be releasing and regulating our emotions. Is it around nutrition? Is it some kind of mind body integration that we have to look at? Can we do some mapping? So identifying mapping, like what's going on and like plan it out and look at where are the areas that we need to change. Can we role play, do some guided visualization? um Is it that we need to do some resource mapping? So helping them find the local organizations or communities that can help them wherever they are. Because sometimes when people are suicidal, it's because they have a lack of resources of like basic needs. And so if we fix that, then we may fix the way that they're thinking. And then last one I have on the list is kind of like journaling. So just kind of reflective journaling. These are just a few ways, it's not an exhaustive list, a few ways that you can think about how you can support your clients because every day is not a crisis. It's just not. We get a lot of people these days, or I see a lot of people these days where, oh my God, it's a crisis, and it's really not. It's like let's pick it apart and understand what's going on underneath. Okay, so here is how I like to explain it, and this is how I use it in my everyday kind of like EAP job. And this is what I have found to be the easiest way of trying to do a quick assessment. So on one end, you see escape. This is where someone is feeling overwhelmed. Maybe they're depressed, maybe they're anxious, but there's something going on with them. They can't really explain it, but they feel like they need to run away. They feel like they need to escape. They feel like they need to just take a really long vacation. But the ultimate thing is that when they feel like leaving, they do feel like if they come back, it's better. They fix their problem. It's resolved. That is escape in my book. Then there's this place of dying where, yes, we think about dying. It's not really necessarily ideation. It's more than, say, like estate planning and dying in the sense of like, oh, when I pass away, my family needs to do X, Y, and Z. It's a little bit more than that, but it's this thought of, I don't want to be here. I don't need to be here, but they're not thinking about ending their life, if that makes sense. It's more of like, um, I can just go to sleep and I'll be good kind of thing. That's kind of where dying is. And then we have our suicidal ideation, full blown. This is where you're thinking about ending our life. That would be the difference on this spectrum. And so when I'm asking clients what where they are, I kind of explain that. And then I ask them, where are they? And then they can kind of tell me. And sometimes they're in the middle, sometimes they're not. And then when they're, especially when they're in a place of escape, this is a good place to validate because you can say, like, oh, when people feel overwhelmed, sometimes our brain just thinks like going away. And that's kind of a normal thought because we have to kind of figure out like, what do we need to do? It's like our way of problem solving. It's the way our brain protects us. It's moving us away from the situation. So then don't forget, if they're thinking suicidal ideation, we have to do plan, means, intent. Like we got to start asking all those heavy questions. Now, if in my world, if you are thinking about dying, thinking about escape, I wouldn't necessarily say that they're even passive on the suicidal scale, right? Because it also depends on the circumstances. It depends on kind of like what are some other things, factors going on. And especially these are the same people that can really talk about their protective factors big time. And so that that's not where they are. They're just trying to figure it out. These are your people that probably need resources. They probably need some extra support somewhere so that they can get off of this scale altogether. On the other hand, when they are having actual ideation, is it passive? Is it moderate? Is it severe? And so I would consider someone passive if, yeah, they're thinking about it, but there's no plan, there's no means, there's no intent, like there's nothing there. That to me would be passive. Okay. And then I would still engage with protective factors. I would still engage with like a plan of a safety plan. I would still do all those things because they're passive. But it doesn't require us to have the same interjection if someone was moderate or even severe on the scale. So that's just kind of like how I like to explain it. If you want this, I can send it to you. Just drop me line, a comment, or whatever. But this was something that I came up with, and I actually gave it to my husband because if you didn't know, my husband is a first responder, but the last year he's been a mental health officer. And so he's doing a lot of risk assessments in the moment to determine if someone needs to go to the hospital. And so this was something that I kind of had with I work with my associates with, but I gave it to him and he was like, "Oh my god, this is like crazy good because it prompts you on ideas or questions that you should be asking." So, and I know that DV is on here as well, but that is for the purpose of sometimes our DV folks fall into suicide risk because of the situation that they're in, and they feel that the way to solve their problem is to engage in suicidal behavior. Okay, so if you guys want that, drop me an email and I will let you know. Okay, so that is what I have. I know that was a lot, y'all. It was a lot. It was definitely a lot. Let me get a few links here pulled up for you. I want you to drop in if you have any questions that I can answer now. Um, so that we can get those answered and we can kind of see what's going on here. Just let me know. I'm gonna get a couple links here so that you guys can um so if you're new around here, I have a Q&A form. I'm trying to find it so I can actually drop it into the chat so you can click on it. Just do the survey so that I know how things went, and then I can maybe make some tweaks or bring you something new. Let me know. If you are looking for an actual CEU out of it, that's the one I'm trying to find real quick. Um, I can't find it. Of course. I had everything ready and then now it's not ready. Gotta love it, right? Let's see. This one might take you there. Any questions come up for you guys? Anything? Any questions? Any questions? No? Not hearing any? Okay. Well, I appreciate you guys. I thank you for being here. If you guys have any questions, just make sure you drop me an email somewhere or a message. Um, and again, I appreciate you being here. I hope you guys learned something. Resource sliding in. Okay, hold on. Let me see. Let's see where we can do that one. We talking about this one? So these are again just some of the places that I got resources from, but you might want to you can check a couple different places for stats. They're all over the place, but a few. No worries, no worries. Any other questions before we go? All right. All right. Well, y'all have a great, amazing day. Have a good morning, a good weekend, and I'll see you guys next time. Bye.